Okay, so it's Friday night, we're in a busy hospital. Phil and I are the radiologists on call, and all of you are our students, and you're going to be following us around the hospital all night long, learning with us about emergency radiology. Okay, so let's go into the hospital, and just before we start, obviously all of the patients are anonymised, and we've also changed some of the details so that the patients are entirely unidentifiable. Okay, so let's take a look at our first patient, and this is a 30-year-old man who came in having vomited many times, and one of the times after he vomited, he developed terrible epigastric pain. So that means pain here in the kind of region between the chest and the abdomen. So we took him to CT, and all the radiologists in the room will recognise instantly when they look at the CT, there's free air in the peritoneal cavity. So how do we know that there's free air here? Well, the reason we know there's free air is we can measure it, and we can compare that to a grayscale. Air is always black, bone is always white, and then everything else is in between. So this grayscale is named after Sir Godfrey Hounsfield, and Sir Godfrey Hounsfield is kind of one of every radiologist's heroes. He was an electrical engineer who basically invented CT, and in honour of that, the grayscale is named after him. And if I measure the density of bone or the density of air in any patient, in any hospital, anywhere in the world, I will always get the same number. And that is the beauty of the Hounsfield scale. And as we go through the next hour, you'll be seeing that we use it a lot. So we can see that there's air around the heart and the esophagus of this patient. Definitely you should not have air there. And that extends all the way up. And if we look at the patient now, we're looking at them kind of front ways on, you can see the air that, again, is between the heart and extending into the abdomen. And then, in fact, that air is coming all the way up here, right up to above the collarbone. So this patient has way too much air. So if I tell any medical student, I've got a patient who's been vomiting, they've got terrible epigastric pain, and they've got air in their mediastinum, I hope they would be able to tell me what's going on with this patient. And the answer is Boerhaave Syndrome. And what that is when a patient vomits so violently and there's such pressure in the esophagus, in the gullet that goes from the mouth to the stomach, that there's a tear in the wall of the esophagus, and the air that was in the gullet passes out into the structures around the esophagus. So this is a really serious problem, and we have to confirm what's going on as quickly as possible so that the surgeons can take this patient to theatre. And how are we going to prove it? We're going to go back to our Hounsfield scale again, and we're going to make use of the fact that iodine is very dense. So we can put iodine into a liquid and ask the patient to drink it, and then watch that liquid pass through the esophagus. So here we're coming down through the patient from top to bottom, and you can see the contrast here in the esophagus all the way down, just filling the esophagus, which is a narrow hole all the way down. But as we keep coming, hang on a second, you can see air again around the esophagus. Remember how we know that it's air because we can measure it and it's black on the grayscale. So we keep coming down and we can see the air around the esophagus, and then we start to see more dilute contrast around the esophagus, not in the esophagus, which tells me, hang on a second, there has to have been a leak. So now we're going to search really hard for the leak in the wall of the esophagus, because that will help the surgeon. So let's keep coming down, and I want you to focus in here. Let's zoom in at this point. So here we can see the esophagus with very dense contrast in it. We can see the wall around it. We can see contrast that has poured out and leaked out, and we can see air. So we know that the leak must be somewhere in this region, and we were able to tell the surgeons that. Tell them, this patient's got Boerhaave syndrome, they've got a perforation, right, take this patient straight to theatre. This is an emergency, and we have to make the diagnosis as soon as possible. If we delay, the chances of the patient dying become higher and higher. And this patient had their esophageal defect repaired, they did very well. Who was Boerhaave? So Boerhaave was a Dutch physician who practiced in the 17th century in Leiden. And he was the preeminent doctor of his day in Holland, so preeminent that when an admiral in the Navy fell ill, with almost exactly the same history as our patient, he was called to see him. So what happened to this admiral was he had a very heavy meal, and it was so heavy he felt dreadful, so he decided to try and make himself vomit. And when he did that, he suddenly had this terrible pain in his chest and upper abdomen. Boerhaave was called to see him, and Boerhaave said very wisely, actually there's nothing we can do for this man, he's not going to survive. And sure enough, the patient did die. And Boerhaave then did a post-mortem on the patient, and in the post-mortem he could see the hole in the esophagus, and he could see the last meal that the patient had had a couple of days earlier. He found some duck around the esophagus. And he published a book on this, telling everyone about the syndrome, which is why it's still named after him 300 years later. And what Boerhaave said was it's really important to correlate what you find clinically with what you find pathologically. And the same is true for radiology. There's no point us just going out and reporting lots of films and never checking what happens to the patient. We have to correlate with what happens to the patient and talk to our clinical team. Okay, so the next patient that we've got to see also has chest pain, but this patient is breathless, and they've just got off a long-haul flight. So the clinicians think that this patient has a pulmonary embolus, a clot that has passed from a vessel in the calf all the way up into the vessels in the lung. So we have to do a CT pulmonary angiogram, which is a specific test to look for clots in the lung, in the vessels of the lung. And what we do, we use that same principle again. We look at the pulmonary artery, and we make the pulmonary artery dense and white by injecting iodine-containing contrast into a vein in the arm, and that travels all the way around the body to the pulmonary artery. So here we are, we can see the pulmonary artery, and as we come through this patient's chest, we start to appreciate that there are filling defects, and these filling defects are clots which have broken up from the leg, and they've travelled all the way through the veins to the heart, to the right side of the heart, and then gone into the pulmonary arteries, and they're blocking the pulmonary arteries. Now this is not good news for the patient, because instead of oxygen coming into the lungs and then diffusing through the blood vessels to the pulmonary vessels and then going around the body, that can't happen. So the patient doesn't have enough oxygen going into their body. And there's another problem that happens. And the next problem that happens to the patient is that there is strain on the heart. So the normal heart, let's show you this little video of the heart beating. So the normal heart, blood comes into the right side of the heart, then it gets pumped out into the pulmonary vessels, the lung vessels, and then it comes back into the left side of the heart and gets pumped out into the circulation to the rest of the body. Now, if that doesn't happen for any reason, or it doesn't happen as well because there's a clot in the pulmonary artery, the right ventricle will start to be under strain because it's pushing against the pressure and it can't overcome the pressure. So in a normal patient, if we look at the heart, we can see the right ventricle and the left ventricle, and the left ventricle should always be bigger than the right. But in this patient, the right ventricle is bigger than the left, and that is a bad sign. And we can measure exactly what the diameter of the two ventricles are, but ultimately, big right ventricle, bad sign. The patient will compensate for a few hours, and then they will decompensate. And actually, this is a really serious condition. The patient develops right heart failure, which we call Cor Pulmonale, and the mortality, that means how many people will die, is 30%. So luckily, radiologists can make a difference, and my interventional colleagues made a difference in this patient. What they did was they threaded a tiny catheter in through a vein in the groin and into the pulmonary artery, and they put the tip of the catheter in that clot, and they dissolved the clot with clot-busting medicine or thrombolysis. And just a day later, after that treatment, the patient is so much better. You can see exactly how much greater the left ventricle is now compared to the right ventricle. So radiologists can make a real difference, not just in diagnosis, but also in treatment. Okay, now, while I've been busy with those patients, Phil also has someone to see.
Thanks very much for that, Elizabeth. Well, we've got a trauma patient that's been brought into our Minecraft emergency department, which you can see there in the back of an ambulance. In fact, that's our miners bay on the right and our trauma bays and majors off on the left side. He's been taken through into resus, so we're going to dash in there and take a quick look at him with our clinical colleagues. So the story here is a 40-year-old chap. He was working on a digger, knocking down an archway when catastrophically the archway collapsed on top of him. So he's been covered with building materials, masonry, which has been lifted off him, sustaining a crush injury. Thanks to the Plymouth Herald newspaper who provided this image of that actual injury, of that actual accident. He's come in and he's had a supine chest film, so he's lying down with this chest film. There's actually quite a bit in terms of the clues to the initial injury and future management from this. Now, the central structures between the lungs, we call the mediastinum, they're slightly subtly widened on this. Okay, it is there. And further down the thoracic spine, so if we look down the midline, one of those vertebral bodies isn't quite normal. It's got a loss of height there, so the suspicion is a crushing type injury. Make matters worse, the patient's not moving his legs, so we're worried about a spinal injury and potentially something going on in terms of his thoracic aorta. Thank you to Sir Godfrey Hounsfield again. He's going to go and have a CT scan. And the CT scan reveals a quite catastrophic thoracic spine injury at T11, which explains the paraplegia, but that's not the full story with this patient. His blood pressure is unstable and he's got chest pain. If we look up at the aortic arch now, so we're up in the chest, that's not quite right. This stuff around the white, dense, contrast-filled aorta is hematoma. There's evidence of leakage there, and next to it, that isn't quite right as well. There's a suspicion of a pseudoaneurysm, so a leakage of blood contained by a very thin layer of blood vessel wall and surrounding blood clot. So he goes into the CT scan and it shows, when we do a 3D reformatting exactly that injury, there's a pseudoaneurysm on the aortic arch there. The management for this, previously in years gone past, it would have been open surgery, but that was associated with a high mortality. The treatment is by interventional radiologists and surgeons to go in through the groin and put a stent graft in. So that's a stent, woven metal with material attached to that. So he's going to go off to the IR theatre. That's our IR theatre in Derriford. And this is our team of radiographers and nursing staff. And we're going to put something in like this. This is a, thanks to Cook, a Zenith Alpha thoracic stent graft. So this goes in from the groin. It goes in initially contracted down. It's then expanded and released over the point of injury, avoiding the head and neck vessels in most cases because we want to preserve the blood supply to the brain and the upper limb. Okay, so this is before we've deployed it. I did this with my colleague, Dr. Richard Miles. And the vessel on the left there is the left subclavian. In this case, we want to not cover that to maintain the blood supply down his arm. And we've released the stent graft there. The first centimetre or so is uncovered, but the rest of it is material, and that's going across our pseudoaneurysm.
May I have a pointer?
Yeah.
And in fact, the stent graft is deployed, and that's in a good position there. So this patient becomes immediately cardiovascularly stable again, and we've healed the leak in this case. Not the end of the story for this patient, sadly. Unfortunately, he's had years of pain afterwards. Of course, he went for spinal rehab afterwards in a spinal injuries unit, but has had significant symptoms and life-affecting injury here with his spinal injury and paraplegia. Thank you, Elizabeth. Handing over to you now. I think there's another patient.
That's right, so we've got another trauma patient, Phil, and this patient is code red. And what code red means is that the patient is going to need blood products, so they're unstable, so we've got to take this very seriously. So for trauma, we basically do a head-to-toe CT, and here we are, we're going to start off in the region of the liver. And if you look at the liver on this patient, we want the liver in general to have the same kind of grey density all the way through. But here what we see is this branching lower density coming all the way through the liver. And what it looks like a great big brown bear has come along and kind of pawed the liver like that. So we just call this a bear claw injury. So there's a big liver laceration, which is concern number one. And then we keep coming down through this patient. And the next thing I'm looking at are the kidneys. So normally when we give that contrast injection, the iodine injection, it goes to all the blood vessels and to the kidneys. And so the kidneys should light up nice and bright, like the kidney on the right. The kidney on the left is not lighting up at all, and that tells me there is no blood supply to the left kidney. So we've got to work out why there's no blood supply. And let's focus in here on the renal artery, so the artery that goes to the left kidney. And you can see it's completely truncated. So something's happened to that renal artery. And maybe it's actually pouring out blood. So I need to check and see exactly how much blood there is around that left kidney. Luckily, it's not terrible, but there's certainly some blood around that left kidney. Okay, the next thing I need to think about is the abdominal wall musculature. So when you look at the muscles of the abdominal wall, you've got on the front the six-pack. Not everyone has a six-pack, I know, including me, but anyway, there is a six-pack, and that's the rectus abdominis. And then when you look around the side of the muscles, you have the corset muscles, the oblique and transverse muscles. Now, in this patient, if you compare one side with the other, so if you compare this side here, the muscles are thick, whereas on this side, they're thinner. And so what this patient has had, and if we keep coming down, I think it becomes more and more obvious. What's happened in this patient is in that very high-speed car crash, the seatbelt has actually dug into their abdominal wall muscles and torn the muscles. And so then what's happened is in that defect of the muscles, the bowel has actually herniated, so kind of prolapsed into the defect in the wall of the muscles. So that's not good news. And the first thing the surgeon asks me, because the surgeons are all standing behind us, kind of asking lots of questions and breathing down our necks, is do we need to do a laparotomy? So the question is really, is the bowel healthy or not? And the way we assess that is the same old principle. We look at the bowel wall and whether or not it's taking up the iodine contrast. So I compare it to some normal looking bowel, for example, over on this side. Let's compare to this bowel. And this bit is enhancing normally, so that's okay. But then come a bit further down and you appreciate that the loops of bowel that I've arrowed are not enhancing at all. So they're very dark, the walls, and there's this kind of funny air material within them which doesn't look right at all. So we say to the surgeons, look, we're very, very worried about this loop of bowel. We think there's no blood supply to the bowel. And this is really important because hours matter with dead bowel. The longer that you leave the bowel without addressing the problem of it being dead, the more complications you get. Okay, so now it's time. You've been with us for a couple of hours already. I think you've learnt quite a lot. It's time for you to help me make a decision about what to do next. So in front of you, you all have these A, B, C, D folders, pieces of paper. And what I would like you to do is to take, this is a very simple voting system, is to take them, you fold them up, and then hold up for me which of those four things you think the surgeons should prioritise. Okay, so should they prioritise the small bowel, first of all? Should they actually go and sort out the liver? Should they sew up the abdominal wall hole? Or should we actually be worried about the renal artery that might be pouring out blood? So you can vote now. It's entirely secret, the vote, because the only people who can see it is Phil and I. Okay? And don't be shy, because you won't be judged on it. Okay, very good, excellent. So it's actually a very hard decision, and you don't want to make the wrong decision, and we went backwards and forwards between A and D, and then in the end we decided A was the right thing to do first. So the patient was taken to theatre, and they had that loop of bowel that was dead resected. And then straight after that, the patient went to the interventional radiology department, and my colleague looked at the renal artery and actually discovered that the renal artery had kind of self-sealed. So that was all okay. And the liver, we actually left it alone. Livers are amazingly resilient. The liver kind of settled down. But those are the kind of decisions we have to make, and we have to make them in conjunction with the rest of the team. We couldn't possibly make them on our own. Okay, Phil, I think there's another patient. Oh no, there's one more for me to see, isn't there, before I go back? Okay, so the next lady that we're going to look at is not a trauma patient. She's a lady who's come in with abdominal pain. Now, when I was a junior doctor 20 years ago, people who came in with abdominal pain, it was pretty straightforward. They went straight to theatre and they had a big scar, a big operation to see what was going on. And the radiologist wasn't really involved, but now things have completely changed and we really are involved. And I think so much for the better of the patient that we're involved. We're called for our opinion. So this lady that we're going to look at, she's got crampy abdominal pain, she's had diarrhea, and looks like there's something going on in her abdomen, some inflammation. So we did our standard CT. And this is the CT, one slice from her abdomen. And if we look here, you can see there's this tubular structure, And this tubular structure is very swollen, it's got very thick walls, it's inflamed. This is the appendix. How do you know what the appendix should look like normally? So I've put a patient with a normal appendix here on the other side, and you can see the normal appendix is a very thin little worm, usually with air in it. It's teeny tiny, it's very delicate, whereas the one in this patient is big and swollen and inflamed. That's not the end of what the surgeon wants to know from us. They want more details. So it's interesting to know why the patient might have developed appendicitis. You can see here this kind of stone, an appendicolith. This stone is in the top end of the appendix, and it probably blocked everything in the appendix and caused all the inflammation to occur. And those are quite common in people with appendicitis. But the key thing to decide is whether or not the patient has perforated. Because if the bowel is perforated, so there's a hole in the bowel, and then pus escapes into the rest of the abdominal cavity, the patient's chances of surviving go down, but also just their whole recovery is going to be more complex, and the surgeons will treat them in a different way. So it's really important to answer the question, is there perforation? And we're going back to our same old principle. We can see a tiny black bleb of air, so there has been a perforation. That means the surgeon's going to treat the patient with antibiotics for longer, and their laparoscopy will be more extensive. Okay, so while I've been busy with those patients, Phil, I think there's another trauma patient for you to see.
Thank you, Elizabeth. It's a busy night in ED tonight, and the patients are racking up, certainly. Okay, so the next one we're going to see, this poor chap has come off his bike. His right thigh is quite swollen. It's been swelling for some hours now. He's cardiovascularly stable, so his heart rate is okay, but he fell off his push bike some hours ago, impacting his thigh on the point of his handlebar. And he tells us it's really increasing in size and it's quite big now. He's going to go in a CT scan, of course, and our thought here is he bleeding? Now you can see the right thigh, which we've labelled there, is actually quite significantly larger than the left. And if you look at the fat, which is the darker grey stuff on the periphery of the thigh, you'll see on the right side it's got that furrier look to it, so it's slightly irregular. Now that's hematoma, that's blood in this case. You see just around the periphery there. Okay, so if we coronally reformat that, so we're looking down the body in this direction, there's a couple of things you can see here. First of all, there's hematoma bulging the fat in the adjacent muscles, and this little blob here is evidence of bleeding from a side branch of the femoral artery. To show that a little bit more finesse on that specific slice on the axial section, there it is, and that's going to be the target for any treatment. Now the options of this chap, could he go to theatre? Well, it would be a difficult dissection with no definite chance of finding it, so that would be a difficult operation for a surgeon. So my colleague Dr. Tarek Adlan and myself, who's my registrar at the time, we took him to IR theatre, that's our Minecraft IR theatre, to operate on him to try and stop the bleeding point. So the approach to this is we go into the femoral artery at the groin and work down the leg. There's a catheter here, and we've gone into this tiny side branch. There's some evidence of mischief, of possible bleeding a bit further down here. Okay, and if we mag up on that and have a look on that area, this blob here is suspicious for the bleeding point, which we've seen on CT. The CT has guided us in on this intervention. So we're going to try and put some embolic coils into this. These are platinum coils, which ideally will stack up and block the blood vessel and achieve clot formation. So before embolization, we've got our blob there of bleeding from these blood vessels which are feeding that, and then post-operatively we're not seeing that anymore. And again, the final result, we put another coil in a side branch next to it, which we thought was also contributing to the bleeding here. I put furry coils because they're platinum coils with polyester and things sewn onto the outside to give them a large surface area for clot to form. Again, a nice neat treatment for this patient. It's avoided an operation and a prolonged hospital stay, prompt and effective hemorrhage control in his case, and it stopped the hematoma enlarging and potentially him losing his leg without hemorrhage control. He went home 24 hours later and made excellent progress with no lasting injury. Okay, what's coming next, Elizabeth?
Okay, so 3 o'clock in the morning, as all of my registrars know, is time for stabbings. So the next patient is a patient who has been stabbed. He's had multiple stabs, again in that upper abdominal region. And I'm going to show you his CT. So first of all, thinking about the knife path, you've got to think about where the knife may have gone. And I think you can just appreciate here in the soft tissues, there's this kind of extra bit of density. This is where the knife has gone in. Okay, but how far has it gone? That's the question. And if we now look around the heart, so remember the heart from when we looked at it before, there is all of this extra blood. Okay, so that's obviously bad news to have blood around the heart. The good news is that the knife hasn't gone into the heart. So we've got to keep thinking about where the knife may have gone next. And the next thing I want to remind you of is the diaphragm, which is the thin muscle layer between the chest and the abdominal cavity. And that kind of keeps the chest and the abdominal cavity separate. And traditionally for surgeons, if you have a stabbing kind of anywhere in this region, you've got to worry about whether or not the diaphragm may have been injured. So here's the normal diaphragm. As I say, it's a nice thin structure. And if we look now kind of axially at the diaphragm, again, you can kind of see that thin muscle layer between the two. Let's go back to our patient, and if you look, kind of draw your eye along the line of this muscle, you'll appreciate there's a gap here. So that knife has definitely gone through the diaphragm. That is not good. He definitely will need the diaphragm to be repaired. Okay, so now we're looking at the patient kind of sideways on. And here's the front of the patient and the back of the patient. So here's the diaphragm, again with the hole in it. And we've got to think again, we know it's hit the heart, so we know there's blood around the heart, but it's also gone through the diaphragm into the abdomen. So we've got to think about the structures which sit underneath the diaphragm, including the stomach. And let's take a look at the stomach, and you're now all experts at picking up little blebs of air. You can see that little tiny black bleb of air in the stomach wall. And what's happened here is that knife has gone straight through the stomach wall. And if he was left alone, that stomach would keep pouring out contents. It would contaminate the entire abdomen and he would be very, very sick. So this man has to have an operation, not just on his chest because of what's happened to the heart, not just on his diaphragm because there's a hole in the diaphragm, but also on his abdomen as well. So that's a big operation. Okay, so now, Phil, I think it's over to you because this next patient who's coming needs an interventional radiologist and you're the man.
Okay, so we knew this patient was coming. He's potentially quite unstable. He's been brought through to the emergency department. We know he's got a high heart rate. He's got a left-sided abdominal pain. He's really quite unwell, so let's have a look at him. So he's 52 years old, pain's radiating around to his flank, and the working diagnosis initially was renal colic, so kidney stones, but something doesn't quite fit. He's slightly too unwell for that, so he goes in for an immediate CT scan. This isn't quite normal. His left kidney, which is here, is being displaced by all this high-density stuff here, which is blood, so fresh blood. So this is indicating we've already found a bleeding. We need to find the source of it now. Okay, we look a bit further down. In fact, he's got an aneurysm from his iliac artery, and that's where the aorta splits and goes down either leg. So we're working towards the pelvis here. The aneurysm is an enlarged artery there, and that's actively leaking. This is a life-threatening situation, and the priority here is to get immediate hemorrhage control. In fact, he needs a vascular surgeon in this particular case. And that's looking at it coronally, so down the body in this particular plane. And we can see all this hematoma on the outside, and that's the enlarged artery there, the aneurysm, which is actively leaking. So he goes for his emergency operation, and he initially does quite well. All seems to be fine. 2 days post-operatively, however, things aren't going quite so well. He develops a sudden facial droop, he starts to slur his speech, and he has reduced power in his limbs. He gets a CT of his head at this point. This is the neurointerventional team at Derriford, and in fact, that's my colleague Dr. Will Adams, who contributed to this particular case, and Dr. William McCono next to him. And this is the CT scan that he has. Now, this is revealing a dark area just there, which is an old stroke. That's not terribly exciting, but a sharp-eyed radiologist spots something else on this scan, which isn't quite right. Down here is the basilar artery, which supplies the lower parts of the brain and the brain stem. That's denser than it should be. This is a non-contrast CT of the head, so we haven't given dye. But he's going to get some dye in a minute to try and clarify what's happening with these vessels. So at this stage, the thought is, has he gotten occluded to a blocked basilar tip? It's subtle, but it's an important finding. So he now goes for a CT angiogram. So we repeat the CT, but he gets contrast instead through his arm. What this does is that the vessels are then outlined beautifully in exquisite detail. We can do 3D reconstruction on them. And what it reveals is this is the basilar artery here. There is a filling defect in the centre there. That's blood clot, okay? And that's a cause of his stroke in this particular patient. But there's something we can do about this particular stroke. This is one we can intervene with. He's got basilar artery thrombosis, and this is a worrying diagnosis. The prognosis is quite variable here, but with very often poor outcomes. And by that we define that as death, dependency, ongoing needs in a high proportion of cases. And one of the things we worry about here is the locked-in syndrome. So he needs an urgent stroke intervention in this case. One of the options would be to give him systemic thrombolysis, so to thin his blood for clot busting. But a more successful way of doing this is delivering it with a catheter-based technique. And there's good evidence for this, for trying to retrieve the clot as a stroke thrombectomy. There's good evidence in the literature for this, and the numbers needed to treat vary in the literature from 2.5 to 7. And what that means is at the lower end there, you need to treat 2.5 patients to get a really good result. So he's off to the neuro-IR theatre. And again, comparing the images here, he's got a catheter that's gone in through his groin, and we're up into the vertebral artery now on the left side. So that's where the clot was in the basilar artery previously. There's a lack of filling of the vessels here that we'd expect to see filling. If I mag up that a bit, there's evidence for filling defects in this area around here in the basilar artery, and again a lack of filling of the vessels here, which fits with his clinical situation. So the approach here is a clot retrieval system. This is a Medtronic solitaire platinum stent retriever. And essentially, if you imagine the job here is one of a chimney sweep, we're retrieving clot on that stent. That isn't a stent that is going to line the vessel afterwards to hold it open. We're literally popping it up there like a chimney sweep to try and retrieve the clot and get it out so that those vessels are cleared of clot effectively. And that's what happened, that's what it looked like. You can see the clot entrapped on the stent retriever there. So post-thrombectomy, you may appreciate we've got to improve filling of these vessels here. There's some spasm of these vessels here, having had a catheter and guide wires placed up there, and that's not uncommon, that will go away. And this is the before and after imaging. So before the stroke thrombolysis, the vessels here have clot in them and they're not filling. Afterwards, we've cleared that, and all these vessels, this new territory here, is reperfusing, it's regaining its blood supply, and he did very well after that. Okay, you've been called to see a patient in minors to give some help down there, please, Elizabeth.
Okay, fine. When I get to minors, I discover there's actually 2 patients to see, so I might be a little bit of time. So both of these patients have fallen on their outstretched hand, and they've got pain in the wrist. So here's the first patient, and this young man has, here's his x-ray, and these are all the bones of the wrist. You can see that they kind of line up like crazy paving. And the bone that we really care about a lot is the scaphoid bone, which is this bone here. And the reason why we care about it is it's the bone that is most commonly fractured, and it's the bone that when it's fractured can potentially have most complications. So I can't see a fracture on this patient, but what are we going to do now? Because they've still got pain. And we've got a couple of options here. So first option is we could put them in a plaster cast and send them, ask them to come back to clinic, and then maybe we'll re-X-ray them in about 10 days' time and kind of keep going. That's option 1. Option 2, we could say to them, look, you'll probably be fine, just go home, and if you still have pain, come back. And then option 3 is we could do some better imaging than X-ray, because X-ray doesn't show all the fractures by any stretch of the imagination. We could do a CT or an MRI. Now, luckily, we happen to have MRI available, so we did an MRI on this patient. And here we've got the scaphoid bone. And what's happened with the MRI is that everything that is bright is fluid and bruised. So you can see that the scaphoid is bright, and that is bone bruising. So there's definitely been an injury to the scaphoid, no doubt about it. But what really matters is there a fracture or not? So I'm going to put the fluid sequence up, and then next to it the white sequence, which is this one here on the right. And this is one where all of the fat in the bone marrow is bright, and that really helps us to look for a fracture line. Lo and behold, there is a fracture of the scaphoid. We couldn't see it on the x-ray, but it's definitely there. So that's really important to this patient, because if you have a scaphoid fracture and you don't treat it, the chances that the patient will either not heal or that a bit of the bone in the scaphoid will actually die and die off and then cause all kinds of problems later on are higher. And that is why, in general, we tend to have a very conservative approach to people who we think might have a scaphoid fracture, and we tend to put plaster casts on all of them. Okay, so here's the next patient, also fell on almost exactly the same history. Fell on his outstretched hand, he's got pain, and here's his x-ray. Now, because we'd just seen the last patient, we were hyper alert. We thought, I think I can see a fracture here. And the MRI was still open, the radiographer hadn't gone home, so she very kindly agreed to do another MRI. And here's the MRI on this patient, completely normal. So that means that this patient doesn't have to have a plaster cast, doesn't ever have to come and see us again. They can go back to their normal life and they'll be absolutely fine. So the advantage of doing an MRI very quickly in these kind of patients is, first of all, you can identify the patients who do need a plaster cast because they will avoid all the complications. But secondly, you'll identify the people who are normal, who don't need all the hassle of having a plaster cast, taking time off work, coming to outpatients clinics, and all the economic kind of disadvantages of that to the country. So there are real advantages to doing advanced imaging straight away. Okay, now my final patient is back in Majors. It's almost morning time, it's 6 o'clock, but I have to see one more patient. And this lady is 80, and a couple of days ago she fell over and she's got hip pain. Now, I've looked and looked and looked at this x-ray, it looks normal, and the person who saw her at the time thought it was normal too, so they sent her home. But she still had pain, and she was desperate, she was trying to get around, but she couldn't. So she came back in, and at that point we decided to do a CT. And here's the CT, and on the CT we can see not only does she have a fracture, but the bone has actually impacted, because poor thing, she was trying to walk around on it, so she's kind of crushed the bone down. So she no doubt had a fracture at the time that we did the original plain film. We just couldn't see it, and that is a hazard of plain films. But now we can see it. And so she can have her treatment, but it would have been so much better if we could have treated her straight away. And when I think about, again, when I was junior doctor, and we used to see elderly people, and they'd come in, they'd have exactly that, a normal x-ray, but pain. And we used to kind of say, well, come on, let's get up and walk type thing. We thought that might be helpful. And I think about all those poor people who actually, they had fractures and we just couldn't see them because we didn't do CT as early as we do it now. And, that's a great technological advance for now. What a shame we didn't have it then. Okay, Phil, just before we end our shift, I'm afraid to say you've got one more patient who's actually very sick.
Thanks very much, Elizabeth. He certainly is. So this patient's having a catastrophic, life-threatening bleed. He's vomiting blood everywhere. He's come in, he's dropped his blood pressure, he's tachycardic, so he's got a high heart rate. And we've got a bit of history on this patient. He's got liver cirrhosis. This is not an uncommon finding, this kind of bleeding in patients with chronic liver disease. And it's because of a thing called portal hypertension and bleeding esophageal varices that is associated with that. The liver has a dual blood supply. It's got hepatic arteries that feed it, but also big portal veins which carry much of the blood from the gut. In patients with chronic liver disease who have heavily scarred, cirrhotic, shrunken livers, they start to process the blood differently. So the blood pressure rises in the portal veins. Now some tiny neonatal infantile vessels start to open up. The blood effectively finds alternative routes to drain. And they form varices. They form them around the spleen, so there are dilated veins there, but also around the lower esophagus, around the bottom of the gullet. Where they come in close contact with the lining of the gullet, the esophagus, they're prone to bleed. And this is something which is the cause of this life-threatening bleed with this patient, bleeding esophageal varices because of portal hypertension. This was my colleague Dr. Nilo Gaffour's case. If we look at the CT in this case, there are signs of chronic liver disease here. That grey stuff there is ascites, is fluid, which again is something we see with cirrhosis and portal hypertension. The liver has a nodular outline, so that's the liver in the centre there. It's not smooth, it's quite irregular. and that bright bit there that's enhancing a little more than the surrounding liver tissue, that is liver, but there may well be a liver tumour developing there as well. And this is the spleen, which is also quite enlarged, and that feeds into this whole picture. The esophagus would be higher up, but it would be around here, and again, there will be some varices that we see on that. So he's got decompensated liver disease, secondary to cirrhosis, with an underlying tumour as well. We look at this coronally, so down the centre, we're seeing a similar picture there. So this is all the fluid, the ascites in this compartment here, that nodular outline to the liver as well. The treatment for this is an interventional radiology one. First of all, he needs to be stabilised, usually intensive care, so be given blood products, get his blood pressure back up, and be well enough to have a procedure called a TIPS, transjugular portosystemic shunt. Now you remember the underlying problem here is one of portal hypertension. So this picture shows the blood supply with the portal vein draining into the liver here, but this is an abnormal, nodular, cirrhotic looking liver. So consequently the blood is backing up. In fact, you get flow reversal in these veins, which then shunts backwards into these new vessels that open up, the varices. So the thinking here in terms of managing this, after having resuscitated the patient with their TIPS, is to form a new connection between the portal veins draining blood to the liver and the systemic circulation by means of putting a stent graft between the two. This pathway does not exist, however, and it has to be created, which is the job of the interventional radiologist. This is a vital stent graft, images kindly provided by Cor, which is partially covered and partially uncovered here. So these are the portal veins here, and this is the systemic circulation. So the stent graft comes collapsed on a deployment mechanism such as this, and this is all done through the veins in the neck. The access is made as a transjugular approach through the neck veins. The patient is brought to theatre under general anaesthetic because this is a traumatic and complicated procedure, and it can be quite prolonged. So my colleague Dr. Kafour has gone in from the neck here. The first thing she's done is the heart is up here at the top of the screen. Her catheter has come down into the right hepatic vein. We go on the right side because there's more liver to work in around here. And she's going to have to make a hole between the hepatic vein and the portal vein to create this pathway. There's the catheter. Catheter's lodged at the bottom. She uses a needle which is about 1 metre long called a colapinto needle and passes that through this catheter and effectively makes a hole through liver tissue to get until she accesses the portal vein. There's a good deal of trial and error involved in this. It's a difficult, long procedure. Sometimes you can hit it fairly swiftly, but it can take some hours to get through to that access. Now, Nila got through very swiftly in this case. So she's gone there from the systemic veins through the hepatic veins here into the portal vein, and that's what we're seeing start to outline with contrast delivered through a catheter here. So the two are now connected between the hepatic veins and the portal venous system in a connection which did not exist before. Having created that tract, she's going to have to balloon it up now to enlarge it. So a catheter with a balloon on the end will be expanded along that new tract in this area here. As the portal vein's been accessed. That's not the whole picture. These are the esophageal varices we were talking about. They've been identified, and this is the source of the bleeding. So a neater way of dealing with this is two approaches to the treatment. Not only are we going to create the new tract with the stent graft, but we're also going to try and treat these varices by embolizing them and deploying something in there to stop the bleeding. And Nilo's done just that. She's deployed an Amplatzer plug vascular occlusion device here, and you'll see at this point that that's the plug occlusion device. The varices have stopped filling, and we now have a stent graft as well deployed between the portal venous system and the hepatic veins. So by this stage we're squirting dye through this catheter under pressure. The plug is doing its job. It's stopping backflow of blood into these varices which are no longer filling. And the second part of the treatment, again, we're seeing the stent graft successfully deployed there. So we'd expect fairly immediate improvement with this stent graft in place with the portal venous hypertension being relieved and the pressures returning to normal. We very often have to go back and sometimes re-balloon these and make sure they're functioning. We did in this case as well. And that the pressures here are as expected. But this is a literally life-saving treatment, having decompressed into the systemic circulation. So that's the before and after. In fact, that's having just gained access. And afterwards, this blood is no longer pooling here. It's travelling beautifully through the stent graft towards the right side of the heart up here. That's been quite a night. I think it's time to go home soon, don't you?
Yep, so it's morning time. So all we can say now is thank you. Thank you, Phil, for being such a great team member. Thank you to all of you for helping us to make our decisions. What are our take-home messages? I think you've probably appreciated the huge technological advances that have happened in the last 20 to 30 years, which have affected all of radiology, but particularly emergency radiology. And that's not just doctors, it's not just radiographers, it's not just everyone else who is medical. It's engineers and IT people and scientists. They've all contributed. And the other thing, which I'm sure you've appreciated, is that the radiologist is really part of the emergency team, and we work with the team. We cannot work in isolation, and they can't work in isolation either. So on that note, Phil and I would like to thank the members of our team who helped us to prepare this, and thank you for your attention.